So this is another session for the PMHNP board exam. Went over the anxiety chapter, and I'm summarizing the Psychiatric-Mental Health Nurse Practitioner 4th edition certification review manual by Kathryn Johnson and Don Vanderhoef, the purple book. So this is the anxiety main points. And again, this is a huge, this is very shrunken summary. It doesn't include everything yet right now. I'm just putting the main points. Levels of anxiety. You can pause the screen if you want to. What to assess for. What medical conditions that mimic anxiety. I think that will show up on the test. Can't spell. The theories of anxiety. Again, this was a whole 2 pages and a half almost. So I just shrunk it to 3 points, but there's more in the book. So, and then of course classifications. And then panic disorder. This is all about panic disorder here. And this is about specific phobia. This is about anxiety treatment. And there's still to be continued because there's a lot of smaller sections to add. There's PTSD I gotta add, OCD. What else did they have in there? A couple more. But anyway, we're ADHD, so we're moving on to the next section. Because I got bored from the anxiety section, let me tell you. Alright, so this one, I did read most of that chapter, the schizophrenia chapter, so now I'm kind of putting down the main points. Let me get into position here. So I think the big thing here is that schizophrenia. Okay. All right, psychosis is inability to test reality. Okay. Manifests as hallucination, delusions, disorganized thinking, speech, referential thinking, abnormal motor behavior, and negative symptoms. So here they're going to talk about which one? All right, so hallucinations is really false sensory experience without stimuli being present. Let's just do the symptoms. All right, so pretty much we gotta know what these things are. So first of all, hallucination, obviously, it's a sensory experience without stimuli. And of course, it can be auditory, visual, etc. I'm not gonna write all that. Of course, it can be tactile, gustatory, olfactory, auditory, visual, tactile, okay? So there's a little note here says that hypnogonic, oh God, hypnagogic. It's the hallucination as you're falling asleep. Okay. This is normal. That's okay. And then you have hypnopompic hallucination as you are waking up. This one is also normal. Okay, so these two things are normal. Good luck remembering those two words. They better not show up on the test. Okay, hypno means sleep, right? Okay. Pompic and gogic. Anyway, delusions. Now I'm having a delusion. False belief. Firmly maintained despite evidence to the contrary. So despite there's evidence that this delusion is wrong, they still want to believe it, right? And then it manifests in, what the hell's texting me? All right, it manifests in, it can be, it says religious, grandiose, somatic, jealousy, okay, or erotomanic. Okay, interesting. Erotomaniac? Manic? All right, disorganized speech or thinking process. Let's just go with the thinking. So they also call it formal thought disturbance. Okay, aka formal thought disturbance. See these words, you never know what's going to show up on the test. That's why. So problem with information, organization, interpretation. So this is manifested through patient speech, abnormal speech, such as loose association, derailment, tangential speech, and word salad. Can't spell today. All right. Derailment, you might ask, what's a derailment? It's shift from one topic to another without logical connection. These are important definitions because if your patients are manifesting these things, you have to know what you're going to call it. What's loose association? What's derailment? What's tangential speech? And what's a word salad? Okay, you got to know the difference. Now, disorganized behavior, childlike to silliness. No, childlike silliness to anger. It's like you never know what they're going to do, right? Unpredictable, anger, disshelved, odd, unusual, dress, inappropriate. Oh, motor activities. So stereotypic motor activity. I did have to look that up. It meant like repetitive, purposeless movements. Like, I don't know, clapping the hands and flapping the hands for no reason. Disheveled. Is this not a word? Disheveled. restless. All right. So these, don't get these confuse you. I just gotta know these. All right, referential thinking. Referential thinking is, I looked it up. Believe that events. Oh, that's when you think, they think events and like ordinary events hold special significance or meaning. Okay, ordinary events hold special significance or meaning. Okay, so they do either thought of insertion, thought of withdrawal, thought of control, thought of broadcasting. It's interesting, you know, and it's hard because if you don't see them in real life, it's going to be hard to like remember all these words, you know. But I hope I see some in the clinical. We'll see. Illusion, misperception of actual environmental stimuli. Okay. So there is an actual environmental stimuli, but the patient have misperception about it. Hallucination is the patient is having sensory experience without a stimuli being present. Okay, there's no stimuli at all. So anyway, these are the main words, I guess, here. And then they move on, they talk about how schizophrenia affects a lot of things, right? Schizophrenia affect the patients. Well, it's not really affect the patient. It causes significant disturbances in functioning areas such as cognition, perception, emotion, behavior, eye movement, and socialization. Okay, so it's not just affecting those things. Anxiety affects those things. Depression can affect those things. But schizophrenia will cause significant disturbance in functioning human, like in their function. And then there is etiology. Remember, every section has some theories. So I put the name of it here, neurobiological. This is saying it's genetics mostly. Neurodevelopmental. This is saying it is abnormal neuron cells. I got for spell check. Abnormal neuron cells due to genetic defects, inadequate synapse formation, that might have happened due to intrauterine insults such as toxins, viral agents, oxygen deprivation, and maternal malnutrition, maternal substance abuse, etc. So this is saying that something that happened during pregnancy that affected the neuron cells to develop properly. And it could be maternal intrauterine insult, so something that happened while the patient's inside the uterus. It could be toxins, viral agents, oxygen deprivation, and then of course if the mom is malnourished or she's having substance abuse problem, this all can affect that. And then we have another theory here, is called neurobiological. This one is saying that there is abnormal brain structure, such as smaller frontal lobe, and the hippocampus and amygdala are reduced in size. Okay. So these abnormalities causes impaired neural communication. Okay, so this is important here because they're going, this is showing signs of schizophrenia is imbalances in these things. So you have high glutamate, low serotonin, low GABA. Now the main one is your dopamine. So you're going to say high dopamine in mesolimbic pathways and low dopamine in mesocortical pathways. Now these two showed up in my exams while I'm doing the courses during school. It showed up in the psychopharmacology class. It shows up in the adults. So I know this will be important to know. So I'm going to have to memorize this. So in the mesolimbic pathway, there will be high dopamine. Mesocortical, there will be low dopamine. All of these are problems that can cause schizophrenia effects like this. You see what I mean? Glutamate will be high. Now serotonin and GABA will be low. Okay, you got to remember that. And then I don't know about incidence and demographics. I don't know if these things will be on the test or not. But I will add very small details about that. So schizophrenia. Oh my God. Okay. So for schizophrenia, onset for men is between 18 and 25, and onset for women is between 25 and 35. Okay, so that's when you first see signs of schizophrenia. Isn't that interesting? So a child can be all, 18 years of his life, and then only when he hit 18 or maybe 25, or 23, 22, 20, that's when they start noticing their schizophrenia. Same with women. She can be in her 30 and then start showing signs of schizophrenia. You see, it's kind of interesting. Unfortunately for men, it's poorer prognosis. Okay. And more hospitalization. Onset for women is 25 to 35, less. Now what they have is they have better prognosis, and they stay away from hospitals more, but they have more dysphoria. New word for you here. It means emotional distress, unhappiness, dissatisfaction. Okay. So women will show more dysphoria if they're schizophrenic. And it says more hallucinations, more paranoids, delusions. Okay. But before the illness, but they have, it's called pre-morbid. So less pre-morbid dysfunction, which means they were functioning okay before the onset. Okay. I hope I remember all this crap. So when someone manifests schizophrenia at a later age, it's probably not structural abnormality, and generally it has better prognosis. But when it shows up earlier, they have more impairment, more evidence of brain abnormalities, okay? So when schizophrenia shows at an early age, it could mostly be related to structural abnormalities. They'll have poor pre-morbid functioning, poorer prognosis in general. But when it manifests at a later age of onset, it has better prognosis. Anyway, you got the point. We're just trying to assess the severity of it and how it's when the patient want to ask you, am I going to be okay? Well, you're going to have to think about this. When did it start? When did all this start? And then we already said this, the possible risk factors. These are the etiology. Okay. Risk factors are these, All right, prevention. Early recognition. Okay. Let's see. We have blah, blah, blah. Significant. What the hell is a prodromal? Can't think right now. All right, prodromal means warning signs. So I need a freaking dictionary here, vocabularies to write here. Warning signs. Yeah, I need this to be all the way at the bottom because English is not my first language. So there's a lot of words that are a little bit hard. Anyway, so early recognition. Odd, unusual beliefs. Feel unliked and picked on. Odd speech patterns, such as, now watch this, digressions and tangentiality. Okay, I need the real definition of it. Goes off topic temporarily, but return to topic. Now tangential goes off topic and never return back to topic. That's interesting, okay? Because this might show up on the test, these words. Okay, so remember those words. Pathognomonic. New word for you. Oh my god, this book won't stay open. It's crazy. I have an ebook version of this, but I don't like it. Pathognomonic. A very specific single signs and symptoms that is present, that if present You can diagnose a disease. Okay, that's the main word here. Pathognomonic. Anyways, so it says there's no single pathognomonic symptom of schizophrenia, but rather a collection of symptoms. Okay? So it's a disease of information processing, symptoms of behavioral and cognitive, the illness associated with marked social occupational function dysfunctioning. Now, DSM-5, this is what's important here, is how do you diagnose it? So this is all cute, but I like to always put my DSM-5 in the top of schizophrenia, because you gotta know these criteria. So you need 2 or more of the following that has been happening for 1 month, okay? Delusions. Oh, at least one must be delusion, hallucination, or disorganized speech. Okay? So these are the 3 things here. Delusions, hallucination, disorganized speech. So one has to be one of, you need 2 or more of these. One of those 2 or more has to be those 3. So these hold heavier weight. Okay, one of them has to be there. All right. So again, they're talking again about this, even though we just talked about it. And now they're talking about delusion is thought withdrawal and thought insertion. What? I thought this was referential thinking. Very confusing me. You know what? I'm going to use my DSM-5 book. Let me pull it. Hold on a second. When in doubt, you just look it up yourself. Because this is always going to be accurate. Okay? It's the DSM-5, for God's sakes. All right. Schizophrenia. Spectrum. Okay, blah, blah, blah. Now here they're talking a lot about delusions. It's important. Hallucination, disorganized thinking, in parentheses, speech. So these are really connected. Okay, there we go. Oh, delusional disorder. I don't want delusional disorder. Brief psychotic disorder. That's not what I'm looking for. There we go. Schizophrenia. 2 or more of the following each present for a significant portion of time, 1 month period. Okay. At least one of these must be number 1, 2, or 3. Okay. These are the 3 we got. The number 4 is grossly disorganized. See how this book doesn't add it, but I like DSM-5, All right. Disorganized catatonic behavior. And the last one is negative symptoms. All right. So for a significant portion of the time since the onset of disturbance level of functioning in 1 or more major areas of okay, so of course there has to be disturbances in the level of functioning. Okay. All right, it has to be there. 6 months. 6 months must include 1 month of symptoms. This is important because later on you'll learn that schizoaffective has to be ruled out, okay? All right, schizoaffective disorder and depressive or bipolar disorder with psychotic features have to be ruled out. Okay, so assess for MDD, assess for mania. Okay, so that's how you, there's schizoaffective disorder, and then there's depressive with psychotic features, and then there's bipolar with psychotic features. So that's why you have to rule out MDD and you have to rule out mania. When I say rule out mania, that means rule out bipolar, pretty much. Okay, so now I feel like, what's the point of having... So there's delusion, hallucination, disorganized speech. Okay. See, I have to put these in certain order so I can remember them. This is the OCD kicking in. Disorganized thinking. These are 3 important points here. And then we have disorganized catatonic behavior. All right, and then we have, the next one is negative symptoms. So all of these were part of the delusion. Jesus. All right, so under delusion, this has to be under delusion. False firm belief maintained by evidence of the contrary. And then it includes referential thinking and delusions of control, ordinary events. Ordinary events also meaning. Okay. All right. Now this is examples of delusions. We have thoughts of insertion, withdrawal, control, broadcasting. So this is interesting because all of these are types of delusions, you know, but it can show up as you're adding something, you're inserting something that's not there, you're withdrawing something that's there, you're thinking someone is controlling you, right? Or you're controlling something ordinary, and broadcasting. So these 3 here. And then we have, see these lists. The list here is a little bit different from the DSM-5. So I'm really trying to merge them together, but I'm going to stick with my DSM-5 because here it's saying grossly disorganized. And they keep putting the speech with, where is this? Disorganized speech. Look here, derailment, incoherence. Remember that word derailment? There it is. It's under disorganized thinking and speech. Okay. Thought disturbances manifested through patient abnormal speech. Loose association, derailment. It's an important word, you know. Shifting from one topic to another without logical connection. They just say things, you know. Tangential speech and word salad. Okay. When it comes to hallucination, is sensory experience without stimuli being present. It could be auditory, visual, and these 2 are normal, but a little bit more here is going to have to be bizarre. bizarre and unorganized type of hallucination. That are not likely to have occurred. So what we're saying here is putting this under my dictionary. Catatonic, by the way, means, where is it? Markedly abnormal movement. It could be staying still or repetitive, purposeless movement. Okay. So now the other thing here to consider, so we're still in the diagnosis and the symptoms. These are important. Negative symptoms is important. Negative symptoms. So that's so affective flat. So flat affect, okay. Diminished emotional expression. Okay, flat affect. Alogia. Poverty of speech. Another word, baby. I told you you're going to need a vocabulary for this. Alogia. Poverty of speech. Part of the negative symptoms of schizophrenia. Okay. Oop. Scroll too much. All right. Apathy. Lack of interest. Avolition. Lack of motivation. Ready? All right. Avolition. Lack of motivation. Apathy. Lack of interest. Excuse my accent. Anhedonia, we know that, and attention deficit. So anhedonia is losing interest in something you used to like. Where was I? I lost my train of thoughts. Okay, anhedonia. Now don't confuse this with major depressive disorder, because anhedonia will be in major depressive disorders. Okay. So here it's saying this has to occur within 1 month. But then here it's saying duration of symptoms last more than 6 months. So it says 2 or more of the following has been present during a 1 month period. And last for 6 months. Yeah, because when it's less than 6 months, it's called something else, you know, it's schizoform. So it's got to say, it's got to be 6 months. Where's my pencil? At least 6 months to be schizophrenia. Months or more. Okay, that's kind of important here. It's interesting how they word it. They're like two or more of the following, each present for a significant portion of time during a 1 month period. So it says all this, and then here it says that it has to be going on for 6 months. Come on, guys, you can just put it all in one sentence. Don't make it complicated for the students. All right. So the other two are disorganized behavior. You know what? I'm gonna go with this here because I don't know. This purple book is confusing me a little bit. See, this is right here. All right, so the first one is delusions. All right, fixed belief, conflicting disorder, variety. So look, referential delusion is still delusion. Persecutory. Okay, I don't know if that's how you say it. It's a belief that one is going to be harmed, harassed, and so forth by an individual, organization, or other group. Referential is that certain gesture, comments, cues are directed to oneself, also common. Grandiose is when the individual believes he or she has exceptional abilities, wealth, or fame. Erotomatic delusions, when they believe falsely that another person is in love with them. And nihilistic delusion involve the conviction that major catastrophe will occur. And somatic delusion focus on preoccupation regarding health and organ function. Delusions are deemed bizarre if they are clearly implausible and not understandable to same culture peers and do not derive from ordinary life experiences. An example is the belief that an outside force has removed his or her internal organs, replaced them with someone else's organ without leaving any wounds or scars. Non-bizarre delusion is the belief that one is under surveillance by the police despite lack of convincing evidence. Delusions that express loss of control over mind or body are generally considered to be bizarre. These include belief that one's thoughts have been removed by some outside. Oh, I love this. This is what thought withdrawal is when you're thinking, belief that one's thoughts have been removed by outside force, that alien thoughts have been put into one's mind, that's thoughts insertion, or that one's body or actions are being acted on or manipulated by some outside force, that's delusion of control. Okay, this is important section, I'm sorry. The purple book did not do a good job explaining delusions. It just listed them like that, and then what? I'm supposed to know all this? So, yeah, this one here, I'm gonna go ahead and do one at a time. So delusion. This is all important here for delusion. Okay, so the first thing is fixed beliefs that are not amenable to change in light of conflicting evidence. And then we're gonna go one by one. So you have this one is one is going to be harmed by an original other group. These are the most common. Okay, it's kind of important. Referential delusion. This one is believe that certain gestures, comments, environmental cues, and so forth are directed at oneself. Okay, and then grandiose, when an individual believes that he or she has exceptional abilities, wealth, or fame. All right. This one is when they think, believes falsely that another person is in love with them. And then nihilistic delusion. Major gastroenterological cure and somatic. Okay, and then somatic delusion focuses on preoccupation regarding health and organ function. Okay. So next thing you need to know. All right, delusions can be bizarre or non-bizarre. Okay. Depending how possible it might be. And I'll just let you as the provider figure this out. I'm not going to sit here and go through examples of what's a bizarre delusion and what's a non-bizarre delusion. But what is important here is this, that a delusion express, all right, here I got to do. I'm sorry, I am a outline person. If something is not outlined properly, I can't function. All right, bizarre or non-bizarre, and then they can express loss of control over mind, body, journal. Oh, so we're gonna go some delusions. Gosh, okay. Thought withdrawal. Word insertion. Delusions of control. All right. Okay. What else do you guys have to tell me? Distinction between delusion and strongly held idea is sometimes difficult to determine and depends on the part of degree of conviction, which I believe is despite clear or reasonable. So you got to take into consideration some religions and some cultural backgrounds, because evil eye, for example, illness are caused by curses, influence of spirits. This might look like bizarre and possibly delusional in some cultures, but generally accepted in other cultures. So, can people stop texting me right now? So this is kind of interesting. The persecutory, I can't say that word right. Persecutory delusions believe that one is going to be harmed, harassed, and so forth by individual. These are the most common, but it could be sign of PTSD if patient has been through torture. It's interesting. Political violence or discrimination. You see what I mean? So you gotta really be careful what you can't call someone schizophrenic if they're having these delusions because of their PTSD secondary to their political violence that they experience and torture. So that's why they have to have one of these three and one more, of whatever. But they have to have two or more of these, not just this one delusion, you see. So that's why. All right, hallucination now. This one is going to have a little section. Okay. So do I experience that cure without external stimulus? All right. So that's hallucinations. See, when things are worded like easily to follow, it makes it easier, you know? So let's see, what do I need from this? All right, next we have disorganized thinking. Okay, if I keep reading the purple book, I'm gonna have disorganized thinking, for example. I'm kidding. All right, so anyway, this is delusion, this is hallucination. And then we have one more here, which is disorganized thinking. Okay. That's the fancy name for it. All right, great. Because I need another name for sure. So that's why they keep mentioning, every time they talk about thinking, they keep mentioning speech. It's because the way to know if the patient's having disorganized thinking is by listening to their speech process. Maybe I might switch from one topic to another. This is derailment or loose association. All right, so listen to the speech. Listen to the patient. Speech. All right. The individual may switch from one topic to another, derailment or loose associations. Be obliquely related to completely unrelated. All right. Oh God. Because the speech represents what you're thinking, the thinking process. If you have disorganized thinking, speech, that means you have disorganized thinking. All right. Let's make your and then we have, all right, God, I need to get through this. And then we have motor behavior, which means movement situation here. All right, so it's, first of all, you gotta know it's grossly disorganized, abnormal. It's not just, oh, he's, anxious, so he's moving his legs, okay? Okay, so they become too silly or too angry to perform activities of daily living. And then catatonic, decrease in reactivity to the environment, ranges from resistance to instruction to maintaining rigid, inappropriate, bizarre posture to a complete lack of verbal and motor responses. Oh, God. So it can also include, you see what I told you? Catatonic is the most confusing. What the hell happened? It's the most confusing word for me. Very freaking confusing because it's both. It could be rigidity, where you're not moving, you're like a rock, or it could be I need coffee. So catatonic. Okay, so it's a big range. It can range from one thing to another. So okay, so rigid, inappropriate, bizarre posture. Okay, mutism, stupor, purposeless, excessive motor activity. See what I mean? Like it's either rigid and excessive. They call it catatonic excitement. Who knew? And then repeated movements like staring, grimacing, and the echoing of speech. Great. Catatonic might occur also in are not specific to schizophrenia. Occur in bipolar. Huh. Weird. Okay. So that's it. I hope I went through. And then we have the negative symptoms, okay, which is those. So there's really 5 things. So like I want to number these. All right. So the first 3 has to be there, and then the number 4 is grossly organized catatonic behavior, and then number hallucinations organized. Okay. Gosh, this was hard to get through. All right, moving on to negative symptoms. One more. I don't know why this was there. I'm just going to put it under vocabulary. Every time you don't know where to put a word, just put it under your vocabulary, your dictionary. All right, negative symptoms. What do you want to tell me about negative symptoms? I think I like this DSM-5 way more than I like the purple book. All right, negative symptoms. Okay, that's important. What's evolution again? Let me go to my dictionary. Lack of motivation. All right. Oh, another word. So asociality. Oh, that means you're not social. All right. Okay. All right, we got the negative symptoms. Now, I do have some information about negative symptoms that I gotta talk about because there's a section here about negative symptoms. All right, let's add some here. We got two things. Negative symptoms are more debilitating than positive symptoms. And negative symptoms seem to persist over time. Okay. And then what else do you guys want to talk about? Factors, predictive, good prognosis. All right. And then there's subtypes. Well, it says the subtypes are not important because subtypes, they have limited clinical value because illness course response to treatment and prognosis are unrelated to the subtype. So why do we have subtypes here then? Well, they're just telling us what catatonic is. I have more words for you. Echolalia. Repeating other people words. All right, excellent water movement, immobility. And then echopraxia. Okay, echopraxia. Imitating another person movement. Who knew? Who knew? I don't remember this from nursing school. It's been a while. I graduated nursing school over 10 years ago. All right. Disorganized. All right. Paranoid. So subtypes are no longer diagnosed in the DSM-5. So we don't need to know them, I think. All right, another word for you. Catalepsy. The person maintained body position in which they are placed. So you put them somewhere, they don't move. Often for an unusually long period of time. All right. Another word for you. Saccadic. I swear like I'm learning a new language. Saccadic eye movement, which means rapid, quick. Okay. Upon physical exam. Okay. All right, moving on. We are subtype of presence of neurological. Oh my God, I have more new words. Okay, this chapter is making the other chapters more easy. Okay. Asterognosis. And this Diadochokinesia. It's very helpful to type correctly too, you know. All right, so this means loss of ability to judge the form of an object by touch. Loss of an ability to judge the form of the object by touch. And whatever this word is, I don't know how to say it. Impairment of the ability to perform rapid alternating. Unable to perform rapid alternating movements. This one might be seen in schizophrenia upon physical exam. That's why we're writing them here. Okay, what else you guys got for me? Oh my God. Chapter does not end. We haven't even got to antipsychotics. How long is this video? How long have I been recording? I don't even know. Oh, it's only been 12 minutes? Oh, what? 1 hour and 12 minutes? Oh my God. Okay, that's a long video. All right, we'll come back to do antipsychotics. All right, let's pause.